presenting a case report to us on portal hypertension. I'm not so sure many of us have seen the case recently, so it looks to be an exciting time with her. She's a consultant pediatrician, a fellow of the West African College of Physicians, and she's going to share an experience with us. In our usual pattern, I'll just briefly hand over to the president of the guild to say a few words before we commence. Over to you, sir.
Yes, thank you very much, Dr. Eletu, for the introduction. I welcome everyone to this meeting, which, as has been said, is a case presentation of a condition that is rare, and ordinarily this would be an interesting grand round in a teaching or tertiary center, where the students and the residents will be very, very interested. And, you know, they will remember everything about these rare cases, so it's heartwarming that we are having this presentation from a private hospital. And it only goes to show the sort of advancement we are seeing in the private hospitals in Nigeria. So I congratulate the private hospital that is presenting this, and I look forward to a very interesting presentation. As has been said, today's meeting is estimated to last no more than 45 minutes altogether, because at the end of it, the members of the guild would wait behind for us to have our annual general meeting, which we also estimate will not last more than 45 minutes. So I crave the indulgence of everyone to let us make this section of the meeting, let us be time conscious, this part of the meeting. So thank you very much. I hand over to Dr. Eletu, who I think is the moderator today.
Yes, sir. Thank you very much, sir, for your kind words. So, Dr. Bekee, I hand over to you. Please go ahead. You have the floor.
Okay. Good afternoon, senior colleagues. Good afternoon. Presentation this afternoon on portal hypertension, a case report presented to, it was co-managed actually. Sorry, my system appears to be hanging. I'll do the case presentation, then I'll talk about portal hypertension, the pathophysiology, clinical features, and management. And so the history, BM is a 4-year-old female who was born in vitro, through in vitro fertilization on the 18th of May 2019. She was premature at 26 weeks, 13 days, was extreme preterm and extreme low birth weight. She was CS delivered on account of severe oligohydramnios and fetal tachycardia. She was managed for prematurity, respiratory distress syndrome, neonatal sepsis, and severe neonatal jaundice. She had exchange blood transfusion. And then she also had umbilical catheterization, for the period she was managed. She was discharged home after 45 days on admission. She was doing well until May 2023, that's at age 4 years, when she developed melanotic stools, abdominal pain, and hematemesis on presentation. This presentation was at UCH Ibadan. This was portal hypertension, prehepatic type, that portal vein thrombosis was made, and she was placed on propranolol, at the first presentation. She represented December 2023 with a second episode of upper GI bleeding and deranged clotting profile. She was again managed for portal hypertension and esophageal variceal banding, but was deferred due to presence of significant gastric varices. As UCH Ibadan, she received vitamin K, propranolol, and ranitidine. And then a CT scan was done, which showed evidence of thrombosis of the right and left transformation at the hilum. The main portal vein appeared patent. Splenic vein was also patent, and there was evidence of massive splenomegaly. And there was also patency of gastroesophageal varices. The final diagnosis made at Ibadan was upper GI bleeding due to intrahepatic portal vein thrombovenous transformation and massive gastroesophageal varices. She was referred to URACare for further management for portal vein recanalization, transjugular intrahepatic portosystemic shunt. That's TIPS, and we co-managed with URACare. That's how come Palon got involved in this patient's management. So the patient was admitted at Palon for preparation for the TIPS, that's transjugular intrahepatic portosystemic shunt. And we did some investigations. We did a full blood count. We showed anemia. Her hemoglobin level was 9.4, as we can see on the screen. She had thrombocytopenia. And her white cell count and differentials were normal. The total was normal. Her clotting profile was abnormal. I'll show the results later. The liver function tests, however, were normal. That's albumin, total protein, and the liver enzymes were normal at this time. The electrolytes, urea, creatinine done also showed normal indices. She continued on her medication. She was on propranolol. And then we commenced intravenous vitamin K at 5 milligrams start and continued with 2 milligrams daily, for 3 days, the period she was here. She was transferred PAC cells to raise her hemoglobin to 10 grams per DL. She received 1 unit of PAC cells before the surgery under laces cover. And the day before surgery, she was given a pint of platelet concentrate. She also received fresh frozen plasma the morning before the surgery. So she went for the surgery at URACare and returned back to us. From the surgery, her vital signs were stable. She was given intravenous furosemide and also had an antibiotic, while in URACare. And then she was monitored for right heart congestion for 24 to 48 hours, and to have repeat furosemide if there were any signs of congestion. We repeated the hemoglobin level, the following month, results later, and we also monitored her for signs of hepatic encephalopathy, because the shunting of blood from the portal system to the systemic circulation could lead to an increase in ammonia level, which could cause hepatic encephalopathy. So we monitored her, and I'm sorry, let me show. These were the results we had on the first day, which was on the 28th at Palon. As we can see, her hematology, basically, like I said, she had anemia, and then post-surgery on the 31st, her blood level, the hemoglobin level had dropped slightly. The neutrophil level went up, the percentage was 75.7 from 54, which she had on admission, and then the absolute was within normal. Lymphocytes had dropped to, that's absolute counts was 0.9 from 1.7, as we can see the results there. So, and then also her platelets dropped, from 88,000 it was before the surgery to 67,000. And also her liver function, like I said earlier on presentation, were within normal limits. The bilirubin were normal, the liver enzymes were normal, protein, total protein and albumin normal. Post-surgery, we were able to do the liver function tests, though protein and albumin wasn't done there. The gamma GT was was elevated, but now reduced subsequently, went down a bit. The enzymes up, on a day after the surgery, as we can see, and by the following day, when we repeated it, the liver enzymes, were back to normal. ALP was high, and that was expected for this growing child, so that was the liver enzyme. The electrolytes, urea, creatinine, were basically normal, all through the period. So she had normal, parameters for the electrolytes, urea, creatinine. And then the other investigations that were done, we did the clotting profile was deranged, like I said, was low. And then the C-reactive protein, which we did a day after the surgery because she developed fever, she did some investigation, which was high, was 90.2. It was very elevated. Her procalcitonin was also high, indicative of sepsis. Malaria was negative because I said she had fever a day after the surgery. We also did a COVID-19 antigen because we suspected, COVID being prevalent this, during that season, that maybe COVID was also a factor because she had lymphopenia. So we did that and it was negative. We monitored her, and by the second day post-surgery, the fever had, resolved. She was no longer febrile. We monitored her through that day. And then the jaundice she had the day, a tinge of jaundice she had the day after, had cleared. And eventually we, discharged her to continue follow-up at UCH Ibadan. So that's the case. And then we followed up. She remained stable. Her liver function test that has been monitored so far has remained normal at UCH. At least we called her to follow up to know how she's doing, and she's doing well. So while here, what she had was the TIPS, the transjugular intrahepatic portosystemic shunt was done while with us, co-managed with UraCare. So that's why we're presenting this case. And so I'll talk a bit about portal hypertension because that's the case we have, we're presenting here. I'll just give us quickly, this is the outline. Portal hypertension, is elevation of portal pressure above 10 to 12, millimeters of mercury, and that's the other definition, is determined by increase in portal pressure gradient. And that's when the difference in pressures between the portal venous pressure and the pressure within the inferior vena cava, there's a gradient is high. So the normal portal venous pressure is between 5 to 10, and the risk of variceal bleeding increases beyond the gradient of 12 millimeters of mercury. Now, the pathophysiology, the portal system includes all veins that carry blood from the digestive system, the spleen, the pancreas, the gallbladder to the liver via the portal vein. And then the portal vein is formed by the union of superior mesenteric vein and the splenic vein just posterior to the neck of the pancreas at level L2. The portal vein is about 6 to 8 centimeters long and 12 to millimeter in diameter. Remember, I said this patient that I'm presenting had umbilical catheterization for some time because she was a preterm extreme low birth weight and was managed for, several things, severe jaundice, had exchange blood transfusion and all of that. So it was umbilical catheterization for some time and eventually had, thrombosis. And the portal vein does not have any valves. The pressure is the same in all parts of the portal system. The portal vein supplies 80% of the blood to the liver and also 20% of oxygen. It's peculiar because it starts as capillaries in the mesentery of the intestine and then ends as capillaries in the liver. This is just a diagrammatic presentation of portal circulation, as we can see, the portal vein there, being formed by the superior mesenteric vein and the inferior mesenteric vein. So they join to form the portal vein, which gets into the liver, and then eventually joins the inferior vena cava. So our patient had a prehepatic, type of portal hypertension. And when there is increase in portal resistance, it leads to a great reduction in flow of portal blood to the liver. Then simultaneously, because of the portal resistance, there's development of collaterals. The collateral vessels become engorged because of the resistance of flow in the portal system. So the collaterals develop when the pressure gradient between the portal and the hepatic vein rises above a certain threshold. And at the same time, the portal flow increases in the splanchnic bed due to splanchnic vessel supply to the mesentery and then the other organs in the abdomen. So there's also increased cardiac output. So these are the portal vein collaterals. At the umbilicus, we have the caput, the umbilical vein being that's the collateral, one of the bypass. So there, the patients can present with caput medusae. At the then within lower esophagus and the gastric, we also have some collaterals there, which form the esophageal and gastric varices. So that forms there. Our patients have that. And then the anus, we also have the liver. So our patients sorry, I don't know if you can still hear me. Sorry, please, can you still hear me?
Yes, we can. Go ahead. Go ahead.
Okay. Sorry about that. Oh, sorry, I'm having some issues. Okay, so our patient had sorry, okay. It's blocking my view. I'm so sorry about that.
Well, one of those things that happens with technology, I guess.
Okay. Okay, sorry, I've been able to resolve it now. Right, so I go on. So I said the patients I'm presenting had portal vein thrombosis, which is a prehepatic type. And there are different causes, as we can see from this slide. Sorry, can you still hear me?
Yes, we can.
All right, so there are different causes, but I'll focus on the prehepatic, which our patients had. For the prehepatic, for this particular patient, or for generally for portal hypertension, they could present with gastrointestinal hemorrhage, which our patients had, and is one of the most common and ominous signs. And bleeding most commonly occur from varices in the distal esophagus and gastric cardia, which our patients had. Rectal bleeding is less common. Variceal hemorrhage may take the form of hematemesis, which our patients had, hematochezia, melena, which our patients had, or chronic anemia. They could also have hypersplenism, which our patients had. The silent splenomegaly is often the first sign of a serious underlying disorder of portal hypertension. Hypersplenism occurs particularly in children with extrahepatic portal vein thrombosis, which our patients had, and maybe that's why we saw those deranged hematological values, like the platelet was very low, the hemoglobin level was low, there was anemia, and also counts. And usually there's hypersplenism, which our patients had, and no other stigmata of liver disease. Our patient apparently had a pre-hepatic type, so there was no stigmata of liver disease. And then patients may present with severe thrombocytopenia and leukopenia from splenic sequestration of platelets and white blood cells. They also have ascites due to hypoalbuminemia, salt and water retention, high level of aldosterone, estrogens, and antidiuretic hormone may be responsible for this. And then the dilated lymphatics in the abdomen from increased hydrostatic pressure in all portal tributaries, responsible for the ascites. And then children with ascites may have advanced liver disease with hepatic failure. Our patients had just mild ascites. And then also they could have encephalopathy, which usually occurs in patients with advanced liver disease. They have levels of liver-dependent coagulation factors and low albumin levels. Remember, I said our patient, our patient didn't have encephalopathy. And if you remember, the liver function tests were within normal. And even the patients never had any signs of, an encephalopathy, drowsiness, altered mental state, or anything to suggest encephalopathy. We monitored all three. So children may have accompanying hyperammonemia, that will cause the encephalopathy, but our patient didn't have this. But this could also and adolescent girl epistaxis and hematochezia. And in cases of advanced liver disease, hemorrhagic complications in the lung may cause severe respiratory compromise. And then they could also present with signs of liver failure if the liver is affected. So these are the presentations for patients who have portal hypertension. And so for the diagnosis, it's very important that we take a good history. In this patient that had, the neonatal, significant neonatal history, preterm, premature, had EBT, it's important to take a very good history of neonatal and, history, other sepsis during neonatal period, procedures during the neonatal period, like exchange blood transfusion that our patients had, blood transfusions, if there's hepatitis B or hepatitis C infections, intra-abdominal sepsis, and so on. And then in the history, we need to ask history about gastrointestinal bleeding, the size, the number, the date, the amount. It tells us the severity and the nature of stools. And then also that is relevant to chronic hepatitis or cirrhosis. And then results of previous endoscopies, if, they've had endoscopies done before for whatever they had. Then general examination, we look out for pallor, jaundice, abdominal veins, if there are any veins. This patient didn't have that, but had, gross abdominal distension when she came to us because had massive splenomegaly. So we look out for liver size and consistency. There's ascites, if there's edema of the legs, and then signs of hepatocellular failure, and then also do a rectal examination, looking out for hemorrhoids and any bleed, Then for the laboratory investigations, we need to do a full blood count that will show us anemia, like this our patient had, leukopenia, thrombocytopenia, and then, they could have a pancytopenia, that's anemia, leukopenia, thrombocytopenia. When there's splenic sequestration, like I said, that this our patient probably had. Function tests will show if there's hypoalbuminemia, and then deranged liver enzymes. Our patient apparently didn't have any of this, and this helps to differentiate cirrhotic from non-cirrhotic portal hypertension and to classify the child as the child POC classification. This is a classification that helps, to assess for the severity of patients who have portal hypertension with cirrhosis. And we do a coagulation profile for this. Our patient was deranged and also viral markers. Remember, I talked about hepatitis B and C. And then also to establish diagnosis, and then when they have gastrointestinal bleeding, to confirm the presence of varices in the esophagus and stomach, we need to do an upper GI endoscopy. Varices could be small, endoscopy, or large, and usually they bleed more when they are large. Then we could also find on endoscopy dilated subepithelial veins. They may appear as raised cherry red spots and other signs of variceal bleeding. And then portal hypertensive gastropathy, which will show us mosaic-like pattern. I think the radiologist will give us, all these details when we need them if we do an endoscopy. Then an ultrasound is key, for a child who has upper GI bleeding. It should be the first imaging study in any child who presents with upper GI bleeding. Because from there you see cavernous transformation of portal vein thrombosis can be diagnosed by ultrasound. And it will also help us to assess the liver for parenchymal abnormalities such as nodularity, presence of cyst, and so on, fibrosis. And then information about the spleen. Remember, I talked about spleen in this child. From the ultrasound, you see, the spleen. And then, like I said, the silent splenomegaly in the absence of other things should give us a clue that this patient may have portal hypertension. And also to know the state, if the child had post-operative patency of a portosystemic shunt, the ultrasound is very useful. And then a Doppler is also useful to measure portal blood flow. It will help us to evaluate the portal, systemic vasculature, the hepatic veins, patency of the splenic and the other vessels within, the portal system. So the ultrasound is very key in patients with upper GI bleeding. Then also CT scan and MRI, they are excellent. They give us, information about intra-abdominal vessels and other details we'll need. So that could also be done. Then other investigations that can be done, if necessary, venography, liver biopsy, and then portal pressure measurement. Because of time, I won't go into details of this, but this can also be done depending on the case that we have, with us. Now for the management, our patients had portal hypertension, which was following portal vein thrombosis and had variceal, hemorrhage. So the general measures to manage acute variceal bleeding is first to resuscitate with blood transfusion and then crystalloid, which we did for this patient when she presented to us, or even at the presentation at UCH Ibadan. Then replacement of coagulation factor deficiency with FFP, fresh frozen plasma. Vitamin K administration key, very important. And then if there's ascites and it's tense, we can reduce the intra-abdominal pressure by cautious paracentesis and also give intravenous albumin replacement to help with the ascites if it's gross. And also the use of spironolactone to help if the ascites is gross. Now for non-operative treatment for this upper GI bleeding, when there's variceal bleeding, and we have the non-operative treatment where we do the pharmacotherapy, endoscopic treatment, balloon tamponade, and then transjugular intrahepatic portosystemic shunt. Now, for this patient, pharmacotherapy was instituted. Remember, I said the child was placed on propranolol, but there are some other vasoactive drugs that could also be used to lower the portal venous pressure, and they constrict the splanchnic arterioles, so as to lower the portal venous pressure. Those are some of the drugs that are listed out there that can be used. Now, for these ones, they can cause coronary vasoconstriction. So when the patient is on drugs like this, we need to do ECG to check the state of the, heart because of coronary vasoconstriction. Then they could also have colicky abdominal pain as a side effect. Remember, I said this patient was placed on propranolol. So for long-term medical management of children with hypertension, they need to be placed on these beta blockers because they help to reduce the splanchnic blood flow and also wedge hepatic vein pressure. And their use has decreased the incidence of recurrent bleeding, by as much as 50%, and they lessen the need for liver transplantation in patients with liver disease. So that's for the beta blockers. Now, the other non-operative treatment that can be done is endoscopic sclerotherapy. Sclerosing solutions include, those like sodium morate, ethanolamine, sodium tetrahydrosulfate, and all of that, they could be used to cause sclerosis of the, varices. But they also have complications like chest pain, ulceration, and mediastinitis, as acute complications. And then for chronic complications, they can cause strictures, and fibrosis after multiple injections. So what this does is, these sclerosing solutions are injected to where the varices are, to cause sclerosis of the varices. That will prevent the bleeding. But this is really no longer, recommended because of the complications, strictures, ulceration, and so on. So endoscopic sclerotherapy is not usually recommended because of these complications. So the other endoscopic management that can be done is endoscopic banding and ligation. Banding was found to be more effective. It's more rapid and safer method of reducing the chance of bleeding from varices than the sclerotherapy, and has less complications, and also long-term rebleeding is lower with this banding. So endoscopic banding and pharmacological control has become the procedure of choice in early therapy of bleeding, esophageal varices or gastric varices. So banding is done, and then the pharmacotherapy as the initial management for variceal bleeding. The other thing that can be done is esophageal tamponade using the St-Stakin Blackmore tube. And this also, the use of this also has decreased with the use of vasoactive drugs, and also endoscopic banding and TIPS, that's a transjugular intrahepatic portosystemic shunt. So the use of this esophageal tamponade, is no longer really recommended because it can also cause obstruction of upper airways, ulceration of the lower esophagus with prolonged and repeated use. So if at all it will be used, it's said it should be used in emergencies, where TIPS cannot be performed immediately, and it should be kept in place for not more than 8 hours. Then the other non-operative treatment that can be done, which was done for this patient, is transjugular intrahepatic portosystemic shunt. So this was done for this patient, and it's a very brief procedure. It didn't take a long time at all. A stent was just applied in between the portal vein and the inferior vena cava, and is indicated for variceal hemorrhage that is recalcitrant to more conservative treatment. So other indications are for patients with advanced liver disease, refractory ascites, hepatic venous outflow obstructions in both transplants and non-transplant patients, and when there's hepatorenal syndrome, and then children with cystic fibrosis, biliary atresia, and congenital hepatic fibrosis. So TIPS is very good and is recommended for patients who are recalcitrant to more conservative treatments like the endoscopic banding. If an endoscopic banding has been done and the patient has been on the pharmacotherapy and is not responding, TIPS is very ideal to use for such patients, which our patients had, and like I said, the patient is doing well. However, there are some complications. The primary limitation of TIPS is high rate of shunt thrombosis, and then puncture of related bleeds, including hemoperitoneum, or stent malposition and migration, or shunt-related encephalopathy, and then deterioration of hepatic function can also occur, or shunt stenosis. These are immediate complications that can occur with TIPS. And then some long-term complications that can occur with TIPS include intimal hyperplasia within, the TIPS, and also complete TIPS thrombosis. So its primary limitation, that's of the transjugular intrahepatic portosystemic shunt, is high shunt thrombosis, high rate of shunt thrombosis. That's the primary limitation. So vigilance is required to monitor for shunt patency. And so this patient is being monitored very closely, and to declot the shunt when it is thrombosed. Now, the use of this stent, PTFE, is a long name. I'm sorry, the name, it's a long name. It's a stent that has been used and has greatly reduced the rate of occlusion when compared to using bare metal stents. So that has helped, for the use of, or in the use of tips. And then also in the management of this patient, there are also operative options. But surgery has no role in primary prophylaxis of variceal bleeding because non-operative management controls bleeding in 90% of patients. So shunt operations can be done as definitive management, non-selective shunts, and then selective shunts where there's end-to-end portocaval shunting, and the other techniques can be done. The other shunting methods can be done. Then also, there's also the non-shunt operations that can be done, and also finally liver transplantation. So for the differential diagnosis of children who have upper GI bleeding, these are the differentials. Like for this, our patient that was 4-year-old before she presented with upper GI bleeding, one would think of erosive esophagitis, gastritis, and in these cases, they will have the epigastric tenderness, heartburn, and the other features we have with gastritis, peptic ulcer, sepsis, Mallory-Weiss tear, if they have severe retching when they are vomiting, and then coagulation disorders, Helicobacter infection, so these are other differentials of children with upper GI bleeding, so Zollinger-Ellison syndrome, and then even medication-induced when they use NSAIDs. Because of time, I'm not going into details for all this, but I want to believe that we know how to differentiate this, from this upper, as different causes of upper GI bleeding. So in summary, in patients with portal hypertension, the number of treatment options have increased, and the options have decreased the need for emergency surgery in children with portal hypertension. So we're presenting this case to let us know that if at all we have any child with portal hypertension, that a transjugular intrahepatic portosystemic shunt can be done here in Nigeria. We can do that, conveniently here in Nigeria. And so in majority of our patients with extrahepatic portal hypertension, which is common in children, long-term survival is significantly better after a shunt surgery than non-operated patients. So that's the case, we had and I've just presented. So thank you very much.
Thank you very much, Dr. Bekee. Well done. I'm sure most of us haven't seen a recent case of portal hypertension, and you've told us clearly that we can actually do some of these cases in terms of the shunting here locally. So you probably will share with us where this surgery was done, and if you have the video of the surgery, maybe you'll post it to us and we can send to the other members of the group. Thank you very much. So it's question time, and I think there's a question here for you. Says Dr. Bonifade, thank you for the wonderful presentation. Could you put into perspective for us the epidemiology of portal hypertension in childhood? Do you have that information?
Okay, well, actually, I scouted for information on epidemiology, the incidence and prevalence. Couldn't get much, in our environment, but what I saw was for the Western countries, and in the range, well, less than 10% basically, so I don't have it right now, but I looked out for the incidence, and the prevalence in our environment, and I couldn't get much. So I think it's something that we should look into and report, except maybe somebody has, a literature I couldn't get access to, but I looked out for it and I couldn't get more. That's why I didn't present the epidemiology I'm so sorry about that. I should have talked about that.
No problem. Thanks. Like we said, I mean, this is a rare case. Not too many of us have seen. I can't imagine seeing a case, but maybe we've seen and we don't, at a time, didn't have the diagnostic tools that we have now to make the diagnosis. So, is anyone asking any questions? You can raise your digital hand and quickly ask the question before we end this session. Okay, there's a question here. It says, how feasible is liver transplantation in this patient?
How easy or how feasible?
How feasible? Feasible.
Okay, feasible.
Do you think this patient will need liver transplantation?
Yes, eventually. Yes. Well, within the country, for this particular patient, well, the parents have the intention of taking the patients out of the country for that, later in life. It was something that was discussed with them, and they plan to do that, for this particular patient. It's a precious child, apparently. It's a precious baby. Yes, so they have that plan to take this particular patient out of the country for a possible liver transplantation later, in life. Yes. So I think that's,
okay.
Yes.
Dr. Laraba asked a question. We need to consider the risk posed by long length of the umbilical catheterization. How long was it left in for, I guess? That's the catheterization. I'm not sure you can answer that because you didn't see this patient at birth.
So, yes, I didn't see the patient at birth.
But probably that could have accounted for the thrombosis that we later developed. It's a possibility, or just saying.
It's a possibility.
Okay. Okay, there's another one here. It says, why would she need liver transplantation since this was not an original liver problem?
Yes, for patients with portal, for patients with portal hypertension, like what has been done so far is just a temporary measure, so she's to be monitored, and hoping that she doesn't deteriorate further. That's the hope. But eventually, if well, at least the bit I know about the portal hypertension, and for this particular patient that we're talking about, yes, so far we have not been able to ascertain if the liver, was severely, affected in any form. But what we're seeing is that the liver has not been affected. That's why I said in the long term, if this patient is followed up and eventually has any, that with the sequelae, long-term sequelae, if the patient eventually has the liver being involved, definitely these patients will need, a liver transplant. What I thought maybe the person was going to ask was if this patient will eventually need another shunt surgery, to do a definitive shunt, surgery, because I know for the tips, it's just a temporary measure to take care of the immediate, complications that we're seeing in this patient. So I know eventually the patient definitely will require more definitive treatments, because like I said, for the TENS, there are complications, there are long-term sequelae. The child will, what has been placed there, there could be stenosis eventually, there could be thrombosis, and all of that could happen. So these patients will require long-term follow-up, and whatever, eventually comes up, I think will be managed according to the sequelae this particular patient, eventually develops. So if the patient in the long term needs the liver transplant, I think, that will probably be done.
Okay, thank you. We're running out of time. Dr. Nifade has her hands up, so I'll ask her to unmute and speak for 30 seconds.
Thank you very much. Thank you very much, Dr. Bekee. This is a very interesting case you have presented to us. But I want to follow up on what Dr. Anga brought up, because we see a lot of preterm babies, and in the private hospitals, we're managing some, extremely preterm babies. And we sort of quickly put in an umbilical catheter. Here in the UK, we don't usually put in an umbilical catheter unless we're pushed to the wall. We'll find the veins for the children, we use the long lines like she said. But if we do put in an umbilical catheter, we sort of check the level and make sure it does not get anywhere. So we x-ray the catheter at the end of insertion. Essentially, we check to see where it is. And you don't insert too long, it's too far in the umbilical vein. I wanted to bring that up. Maybe it's something we will need to look into. I also want to bring up the points that Dr. Bekee has just addressed. It is not over until it is over. So how much, counseling did these parents receive to know that, okay, they've put in a shunt there, that is not the end of the problem. So, it would be nice if, as practitioners of pediatrics, we sort of, counsel our patients, we explain to them the complications, we explain to them what to expect in 1 year, in 5 years, in 10 years, etc. Thank you very much.
Thank you very much, Ma. So the last question, a comment and a question, Dr. Uwaje says, I saw a case of massive bleeding esophageal varices a few years ago, and we're thinking was due to umbilical catheterization as a neonate. She's now asking, should we be intentional in screening ex-preemies for such complications like portal hypertension and bleeding esophageal varices? Your comments, Dr. Bekee.
Okay. Yeah, thank you very much. I appreciate the comment, that was made about the umbilical catheterization, because really, that's what we practice here in most of the hospitals. We still do umbilical catheterization, and I'm sure we'll all agree with me. So it's something we need to, I think, look into again, reevaluate how we're doing it, and if we can go the other way, use long lines, just like we've been told, and also for the extreme preterms, yes, sometimes we might say these cases are not so common, and that's because we don't look for them, or maybe when they present, we don't remember to ask, about their neonatal history and, use of umbilical catheterization. So I think it's something we should actually, put into practice. That's remember and evaluate all preterms, who have been catheterized, look out for these things so that we can, catch them early and intervene early. That's what I'll say.
Thank you very, very much, Dr. Bekee. It's been wonderful sharing your experience with us. And I think some of us will call you later on to have an idea. Maybe we can see the videos. If it's possible, we probably will post it to the group so that all of us can watch and see what has happened. So once again, we say a big thank you for allowing us to use you as a guinea pig, like I said to you much earlier. And it's good that we're sharing experiences like this so we know what is available locally. If you didn't present this, probably if we had seen cases like that, we'll have just said, okay, get onto the plane and go and join Dr. Onifade in the UK, now that we know where she's calling from. So thank you very much, and thank you again. Dr. Mubolaji Lawal, a few words before we go into the AGM.
Yes, thank you very much. It's turned out to be a very, very excellent session. And I want to thank and congratulate the presenter, Dr. Bekee, for doing full justice to this to the topic. On a general, and also all the questions and comments, very excellent comments from everyone, including Dr. Onifade and Dr. Anga and Dr. White. So it's what I want to bring out on a general note is the value of partnerships in management of rare and difficult cases like this. It struck me that 3 hospitals were involved in the management of this case, from UCH Ibadan to Uracare, and then to Pelon Memorial. And one has to give credit for all the actors in those facilities for being able to partner together to save the life of in this case, a child that is in need. It was obvious that not one of them could have done it on his own. So I want to congratulate the presenter for this, and to Pelon and other facilities involved to keep up this kind of partnership, and to use it as a point of recommendation for everyone else, that we just have to partner with each other in order to achieve results for our patients. So on that note, I want to thank everyone, and I'll hand over to Dr. Elitu to close the meeting.
Thank you very much, sir. I want to say a big thank you again to all of us who have been on the call. For those who are members of the Guild, we ask that you kindly stay behind for a short AGM. And for the other members who may be exiting, we hope to see you last Thursday in the month of July. Thank you very much. And Dr. Bekee, a big thank you again to you and Dr. Onya for presenting this case. Thank you very much. God bless.
Thank you very much.